you. I would now like to invite to the podium Darren Sather of WorkSafe BC to introduce our next speaker. Thank you.
Good morning, everybody. Thank you very much for the invite. Dr. Robin Green is a clinical neuropsychologist and senior scientist in cognitive neurosciences at the University Health Network, better known as KITE, and the Saunderson Chair in Acquired Brain Injury. Her program of research addresses brain and behavioral mechanisms of recovery from traumatic brain injury and the development of interventions based on these findings. Her lab has helped better understand impediments to recovery, challenging behavioral, challenging prevailing assumptions of moderate to severe traumatic brain injury as a static disorder, and reconceptualizing it as progressive with early recovery of brain and behavior, followed often by declines in the months and years post-injury in many. Encouragingly, the lab has identified novel, modifiable post-injury treatment targets and has been using these findings to develop interventions for mitigation of decline and improvement of clinical outcomes. Dr. Green and colleagues established the Tele-Rehab Center for Acquired Brain Injury to treat and study the enduring effects of mild to severe brain injury and of any etiology. Patients across Ontario receive remotely delivered group-based assessments and behavioral interventions, all pro bono. The clinical findings are used to continually enhance treatment. The center was created to address a considerable gap in treatment for patients in chronic stages of injury and provides access to evidence-based treatment for patients regardless of geographic location, mobility restrictions, or socioeconomic status. A future goal is to treat patients in other provinces as well. Dr. Green is a co-founder and co-lead of Echo Concussion. She is a neuropsychology lead for the Canadian Concussion Center at UHN and a professor in the Department of Psychiatry, University of Toronto. She completed her PhD at Cambridge University and her clinical neuropsychology training at the University Health Network in Toronto. So please join me in welcoming Dr. Robin Green.
Very much, Darren. Let me know if it's a little blurred. Sorry, just had to correct this. You know? Feedback. Okay. Can you hear me all right? Doesn't sound too blurry. Do you want to just check it for me? Okay. I'm gonna go without my headphones and mic, and I hope you can hear me all right, but I'm hoping someone will give me an indication if you can't. It's a pleasure to be here. Thank you so much to Amanda and Lydia for the invitation. Do want to pay my respects to Dr. Karen. I hope he makes a good recovery. Okay, so I'm going to share my screen now. And so I think this is working. So as you know, my talk is on identifying and filling gaps in treatment for people in the chronic stages of brain injury. So Dr. Kennedy was speaking about a vulnerable population, and I'm going to carry on talking about a very vulnerable population as well. No conflicts of interest for me, and here are my disclosures. So I'll talk first about treatment gaps in the chronic stages of injury. I'll talk about resources, but also misdiagnosis as one of the big issues. I am going to talk about the need for treatment in the chronic stages of injury. And then I'll focus on what and how to treat, some ideas for you. And then I'm going to talk about our Tele-Rehab Center for Acquired Brain Injury. And as you heard, actually, this might become a little bit more relevant to you as we're hoping to expand our center outside of Ontario and across a few provinces of Canada, including British Columbia. And we have some of your colleagues who are our partners. This is my fantastic lab, and I've circled two people who are particular leaders in the lab, Brenda Colella and Gideon John. Okay. So I don't know if you can see behind me, by the way, but it's that my whiteboard says, "Hello, West Coast Brain Injury Conference attendees." Okay, so Maslin DeWitt in 2010 pointed out to us that moderate to severe traumatic brain injury is a chronic disease, and really it's something that wasn't conceptualized that way before broadly, and still it's not always conceptualized this way. But I think all of us here know that traumatic brain injury can cause lifelong disability. There are an estimated 150,000 people in British Columbia, 500,000 Ontarians who are contending with lifelong disability, from mild to severe TBI, enduring cognitive, motor, mood, and psychosocial impairments. And when I say chronic, I'm referring to months to years to decades post-injury. But there's this dearth of publicly funded treatment for people who are in the chronic stages of traumatic brain injury. So why is that? Obviously there's a limited resources, limited availability of treatments in the chronic stages here in Canada, but all over the world. And that's because where there are public services, most of the care is front-loaded in the first weeks and months after injury for most people, unless they're lucky enough to have insurance. We can, as an aside, we can think of some system level solutions that are starting to be taken up, like redistributing therapies, which often are run on a shoestring, to offer later stage treatments, and a really cost-effective way of carving out some of the existing resources is to deliver group-based, remotely delivered treatments. And I'm going to return to this when I talk about the Tele-Rehab Center. Another reason a lot of people miss treatment in the chronic stages and are walking around with persisting symptoms of brain injury, my focus in particular has been on traumatic brain injury, is that sometimes the diagnosis is just missed. When it comes to concussion or mild traumatic brain injury, we know that 20% or so of people have enduring symptoms that are in need of treatment. But the part of the problem is that the acute diagnosis can be challenging, and as I mentioned, is often missed. And I want to just sort of in service of that, I want to bring to people's attention, there's a new set of diagnostic criteria for concussion that have just come out in preprint. In fact, one of the lead authors is from Vancouver Coastal Health Research Institute and UBC, Noah Silverberg. And here are those new diagnostic criteria. So you can see that mild TBI is diagnosed following a biomechanically plausible mechanism of injury with one or more of the criteria listed below met. So that's one or more clinical signs. So for example, loss of consciousness or post-traumatic amnesia, at least 2 acute symptoms like headache or memory problems, and at least one clinical or lab finding attributable to brain injury. And the third criterion is neuroimaging evidence of TBI. And to be a little more nuanced about the diagnosis, other co-founding factors can't fully explain all of these symptoms. You can pull up this paper, and if you prefer, there's a figure, a visual representation of the diagnosis, the diagnostic criteria. So it's really, I think, a helpful figure. But what I really wanted to point out is that, the clinical signs And symptoms can often be that are referred to in those criteria, like loss of consciousness or post-traumatic amnesia, can be difficult to identify because often the events are unwitnessed. They occur in a really chaotic situation like a party or a sporting event or context of a fight. They also may occur in the context of substance use, where it's hard to tell the difference between alcohol and cannabis effects from concussion effects. Acute and subacute symptoms can be like headache or memory, can sometimes be misattributed to a hangover, to flu, to stress. And of course, often neuroimaging and neuropsychological tests when they're given are often negative. Even in the context of more severe brain injuries, all the way from mild to severe TBI, in dual diagnosis, we can see a lot of missed traumatic brain injuries. And this is probably not surprising. So often, if you think about someone who comes into emergency with a very with a range of injuries, including a spinal cord injury, acute medical attention is going to be focused on other things than the possibility of a brain injury, unless it's a very dramatic brain injury. Might be focused on other life-threatening injuries like crush injuries to lungs or paralysis. The other thing is that sometimes we see this misattribution of the TBI symptoms to the reaction to the spinal cord injury or to the medications like opioids that are very psychoactive, rather than to brain injury. So a person is very emotional, they can't focus, they can't retain anything, but instead of identifying that as possible symptoms of traumatic brain injury, they get ascribed to the, some facet of the spinal cord injury. And our group actually did some research on this. We took 135 patients in our spinal cord injury program who had a traumatic spinal cord injury, car accident or fall. And we found in our study that 40 to 60%, depending on how you did your diagnosis, had a comorbid traumatic brain injury. Remarkably high number, and not inconsistent with a number of other studies. But we also found that of those, 60% of the traumatic brain injuries had not been clinically diagnosed in emergency, in acute care, or in inpatient rehabilitation. So a lot of misdiagnoses. And I thought I'd give you a couple of case studies just to really drive home the point. So this was a patient of ours. She was a 38-year-old female and a senior executive of an international company. She was a really high-powered A-type person. She was on a moving transport bus at the airport, and a vehicle stopped suddenly, and she sustained significant musculoskeletal injuries that affected both of her upper and lower extremities. So she received a lot of physiotherapy and occupational therapy for 6 months, and things were fine. When she returned to work after receiving that therapy, however, even though she'd been formerly known as this great multitasker with an impeccable memory, she was now struggling when she had more than one responsibility at a time. She was forgetting appointments, forgetting the content of conversations. And at that point, her occupational therapist asked if she'd ever had a neuropsychological assessment. So she was then referred to us, and we saw impairments to executive functioning, attention, and memory revealed. But what's really interesting to note, and this is a not uncommon scenario, all of her capacities on our neuropsych testing were actually in the mid-average range. But the thing is, her estimated pre-morbid functioning was actually in the 99th percentile. So these average scores represented a very notable decline for her. And once she was in her more demanding environment at work, the challenge, her impairments due to traumatic brain injury were revealed. And at that point, an MRI of her brain was ordered. Here's another case for you. So this is a patient, he was a 35-year-old university educated male, sustained a spinal cord injury in a car accident, which occurred when he was briefly unbelted in the back seat of a car. He was tending to a child. And although he sustained a traumatic brain injury at the time of injury, it wasn't initially diagnosed. So while he was an inpatient on the spinal cord injury program, He regularly missed or was late to his rehab sessions because of confusion regarding his schedule and forgetting appointments, especially when he was just verbally informed of them. He was branded as a difficult patient because of his seeming non-compliance with his sessions. And also because of a lot of behavioral incidents, outbursts that were occurring, including anger, aggression, and crying. Of course, the issue was that none of these were attributed to the TBI that he was contending with. So I want to move on to now, so I've talked about, the gaps in treatment in the chronic stages of injury, but now I want to talk a little bit more about why we actually need that treatment. So one is the prevention or the escalation of concussion symptoms. And we sometimes talk about the vicious cycle of concussion. So you might be familiar with this. So a concussion causes, let's say, one or two somatic symptoms like headache. And that headache in turn causes problems falling asleep. And those sleep problems in turn give rise to some anxiety and maybe a little bit of depression. And those symptoms give rise to even worse headache and worse sleep problems. And those sleep problems and the anxiety now contribute to or exacerbate an array of cognitive symptoms like attentional problems, memory problems. And now we're into this vicious cycle of concussion. It's important to note that early education can actually help to preempt this. There's nice data showing that early education about concussion and how concussion unfolds can help to preempt this vicious cycle in the first place. But once it gets going, it's really important for patients to get treatment to interrupt that cycle, treat each symptom on its own, and help people to get back to where they were before the concussion. Another need for treatment in the chronic stages of injury is in those patients that I was talking about with dual diagnosis of spinal cord injury or musculoskeletal injury and traumatic brain injury. There's findings that patients with spinal cord injury have poor functional recovery in the context of a comorbid traumatic brain injury and with increased risk of complications. Really need ongoing rehabilitation for traumatic brain injury to optimize the recovery from the spinal cord injury, and also to ensure optimal ongoing management of the complex health needs that a spinal cord injury or also musculoskeletal injuries can give rise to. Safe transfers, managing pressure sores. Also, it's important to address the TBI to help an individual who is already contending with a spinal cord injury to get back into the community, to facilitate that community integration. A third reason for treatment in the chronic stages is, this is tied to a lot of research that we do. We find that in moderate to severe TBI, there are a lot of declines in those chronic stages. So I'm talking specifically now about moderate to severe. I'm not talking about concussion, but there's growing evidence of declines in cognition, mental health, and brain structure and function. So I'll just get a little more specific about that. So we have run this central program of research called the TBI, the Toronto Rehab TBI Recovery Study. And what we do is we follow patients who come into our inpatient neuro rehab program, our ABI program. We follow them from 2 months to half a year to a year, and then several years post-injury. And we give them a whole range of cognitive, neuropsychiatric, and imaging assessments. These are all adults, and on average, they have a high school education. And what we have found in these studies is that, that there are these declines. And so, for example, in one study, we looked at the proportion of people who cognitively declined across time. We classified people as a decliner if they declined using something called the Reliable Change Index, which takes into consideration the noise in testing, or the error of measurement, if people declined on 2 or more of the 12 cognitive tests they were administered. And what we found was that when we looked from when we looked from 1 to 2+ years post-injury, a little over a quarter of patients showed decline as we defined it. And then we reassessed people in a separate study with non-overlapping patients, 48 additional patients, and we found exactly the same prevalence of people showing decline. And the other thing that we found was that there was an increasing proportion of people showing that decline as we moved further from brain injury. So from 2 to 5 months, from 5 to 12 months, and from 12 to 24 months, we see more people showing these declines. And those declines were associated with progressive hippocampal volume loss. I'm going to come back to in a second. We also looked at people with, what I do want to say is that people are showing recovery of the majority of their cognitive functions over that time, and the majority of patients are showing cognitive recovery. It's just that there is, within that context of behavioral recovery, this deterioration in some areas in some people that's also occurring. And we want to tackle that so we can improve people's outcomes. We also did something called a trajectory analysis. We followed 123 patients across time from 2 to 5 to 12 to 24 months and more post-injury. And what we looked at were clusters or subgroups of patients who were showing sort of different patterns of recovery. And what I really want to draw your attention to here is that there are these 2 subgroups, both when we look at anxiety changes across time and depression changes across time. So 15 to 20% of them, of our patients are showing by 2+ years post-injury, quite clinically significant symptoms of anxiety and or depression. The other thing I want to flag is those subgroups who are struggling, they're disproportionately more younger male, and they're not returning to work as readily. And lastly, we've done a lot of research looking at the brain, and what we see are these different signs of shrinkage of the whole brain, of substructures, of loss of white matter integrity, and declines in functional connectivity in the chronic stages of injury. And this is research that our group has done and other groups have done, and I can certainly answer questions about the details of all of this in the Q&A. So just in summary, we see at least a quarter of patients showing cognitive declines from 1 to 2 years post-injury, and an increasing proportion of patients with atrophy the further they get post-injury. We see a substantive number of patients whose symptoms are escalating into the clinically significant range by 2+ years post-injury, and it's disproportionately the younger males that are showing this, and it's associated with lower return to productivity. And we also see these progressive brain structure and function losses across time. Also, lastly, what we saw was that early hippocampal volume loss was associated with subsequent cognitive decline, particularly verbal retrieval. So it's really important for us to be tackling patients in the chronic stages of injury so we can try to offset these different kinds of declines. So I've mentioned that we need treatment in the chronic stages to address the vicious cycle of concussion, to ensure optimal recovery and management of comorbid injuries like spinal cord injury, to offset decline, and then more generally, again, back to this point that this is a chronic disease and patients have ongoing symptoms that warrant treatment and that still respond to treatment. So patients can get a lot better. Okay, so I'm going to talk now about identifying what and how to treat, some ideas from our team, ideas from the literature, and ideas from our own lab. So in very broad strokes, we can talk about two different ways to treat. We can talk about compensatory and we can talk about restorative approaches. By compensation, I'm referring to ameliorating a person's symptoms by bypassing the symptom, bypassing the problem to help improve functioning in everyday life. So for example, if I can't use my right arm to brush my teeth, I will use my left arm to brush my teeth. If I can't use if I have compromised memory for visual or visual spatial information, I'll compensate by using verbal encoding strategies, verbal memory strategies. Restoration of function refers to trying to get the brain back to where it was, trying to change the brain, to grow new brain, to restore original connections. It also refers to protecting the brain. You can think of use it or lose it. So prophylaxis. In terms of the compensatory approach, I want to flag that it's really important to just treat the symptom regardless of the etiology. When we talk about prolonged symptoms of concussion, we don't call it post-concussion syndrome anymore. It reflects our neutrality about the etiology of the underlying cause of symptoms. If someone's depressed after they had a concussion, treat the depression however you would treat depression. It doesn't matter whether it rose from organic consequences of the concussion or not. The other thing I want to bring your attention to in terms of treating symptoms is these new guidelines. These are just out in the Journal of Head Trauma Rehab. So a series of patients called the INCOG Guidelines for Cognitive Rehabilitation Following Traumatic Brain Injury. So it's a series of, I think it's about 7 articles. There are 80 clinical, very concrete clinical recommendations and comments on how to implement the recommendations. And these recommendations are developed in separate patients for post-traumatic amnesia, for attention, memory, executive function. Our lab was involved in the executive function one, and for cognitive communication. In terms of restoration of function, there are 2 really important principles that you may be familiar with: environmental enrichment and allocentric spatial navigation, which people are less familiar with. Environmental enrichment refers to continuously novel, challenging, complex, engaging, and intensive cognitive stimulation. You can think of use it or lose it and the importance that we always hear about that. There are a lot of neural and cognitive benefits of engaging in that kind of ongoing cognitive stimulation. And our group did some research that revealed that in the context of moderate to severe TBI, when patients had less cognitive stimulation in the early months post-traumatic brain injury, there was greater progressive hippocampal volume loss associated with that. So we saw a direct connection between cognitive stimulation and protection of the hippocampi. Another kind of cognitive stimulation is called allocentric spatial navigation, and that's where we navigate through space using a spatial reference set of coordinates that are separate from ourselves. So instead of saying, okay, to get to my destination, I'm gonna use my GPS, or I'm gonna use I'm going to turn left at the bank, and then I'm going to turn right when I get to the main intersection. Rather, you actually kind of have a mental map of the space or of the spatial coordinates. And when we can do that and navigate using a mental map, that confers all kinds of benefits to the brain. So it's associated with a larger and more activated hippocampi, increased resilience against neurodegeneration, and higher cognitive function. So, for example, an illustration that you're using a mental map would be, okay, I've got to get to a particular destination. Oh, there's a road that's blocked. That's okay. I can use this map in my head to get around, to still get to my destination, because I'm not I haven't memorized the route to get there in that egocentric way. Okay, so a really nice study in just healthy younger and older adults found that after 16 weeks of allocentric spatial navigation training, it was 1 hour a day for 16 weeks, it reduced aging-related hippocampal atrophy and improved memory. So we actually developed an intervention protocol for people with traumatic brain injury, and we also applied it to people with multiple sclerosis, and we are collaborating with people in British Columbia. I've listed some of the names here. We developed this protocol that harnesses both environmental enrichment and allocentric spatial navigation. And what patients do is for an hour a day, 5 times a week, for 16 weeks, they navigate different cities of the world. And what we're doing in this study is we're measuring pre to post treatment memory, and we're looking for effects that generalize well outside of our training scenario and into everyday life. And we're also measuring hippocampal volumes and other parameters. And the study's been going extremely slowly, but what I can say is that the results so far are very promising, and people are interested in getting engaged in this study. They can feel free to email me. So now I'm trying to leave a little bit of time for questions. So I'm just gonna talk about the Telerehab Center for ABI, and I particularly wanted to talk about it in light of the fact that we are planning on moving into to try to treat people who are in British Columbia. So I'm gonna tell you about it, but kind of quickly. Okay, so what we do is we provide remotely delivered group-based care. Right now it's across Ontario. We try to get way into the north. We provide the services pro bono to patients, and we're trying to ensure equity of access so patients can get access to these therapies in the chronic stages of a brain injury. It also includes patients with multiple sclerosis. We can get treatment to patients regardless of their location, their financial status, whether they have impediments to traveling. This approach is scalable. So I was talking about options for, program. We are funded. This is all operates under the auspices of research, even though we take clinical referrals. I'm paid as a scientist, and this is under the umbrella of KITE Research Institute. But we've all gotten really familiar with remote delivery, but this remote delivery and this group-based approach is really cost effective, and it's something that I think rehab programs should be thinking about to get treatment to their patients in the chronic stages of injury. And of course, as I'm saying, it's cost effective. Okay, so the aims to help fill this critical gap in clinical care for people in the chronic stages of ABI, to improve brain health, cognition, mood, coping, self-management. We really try to empower people and help them to self-manage their symptoms, and to promote community integration, trying to offset the impact of brain injury on family. We're providing evidence-based treatments, and what we do is we update our treatments as our knowledge advances, and we're trying to, an aim is to treat beyond Ontario, and we integrate research with clinical care in order to improve treatments and develop new treatments. So what we do is we ask every patient that comes through that's clinically referred if we can use their clinical data for research purposes. Every patient anyway gets outcome measures when they first arrive, before every treatment module of the center, and after every treatment module, because we want to make sure that our interventions are actually working. And so we say, can we use these not just for quality assurance, but for research? So I'll tell you a little bit about the research so far. But some of the targets in our center come directly from our own research. So one, for example, we're very interested in focusing on anxiety, because we found in our research that higher anxiety was something else that was associated with reduced hippocampal volume loss in moderate to severe TBI. Depression, we know from other literature, is associated with hippocampal volume loss. So these are important targets in our center. We also found, as I may not have mentioned earlier, we find these declines in executive functioning in the chronic stages of traumatic brain injury. And so that's another important target for us. And because of the vulnerability of the hippocampi, we're really interested in focusing on memory as well. So here is a sample of our treatment modules. We have something called the Concussion Education and Symptom Management Program. I'm gonna tell you a little bit more about that in a moment. We do goal management training, which we've adapted for people who have cognitive impairments, adapted it for group-based online delivery. We deliver cognitive behavior therapy, for which there's lots of evidence for benefits for people, even with very severe traumatic injuries, very severe cognitive impairments, and delivered remotely. We've done that ourselves. We've looked at that in some research studies ourselves, I meant to say. We do mindfulness skills training. We do emotions and stress management. This is another new module that synthesizes existing approaches. We also do relaxation skills. We're very conscious of how we sequence our modules to target symptoms that might get in the way of benefiting from other modules. And so just a little bit of data on the center. So feasibility in our first 120 patients, so I should mention that we've been going for a few years. We have, I think we have close to 9,000 patient visits, and approximately 400 patients that have gone through, and really on a shoestring. We have very few therapists, but we bring in a lot of clinical trainees to help us deliver treatments. Our retention is high in all of our different groups. The weekly therapy adherence is quite high. And in terms of completing the outcome measures, we actually get quite good adherence, and that's really important for us, again, so that we can look at the effectiveness of what we're doing. When we look at the efficacy specifically of goal management training, we looked at pre to post treatment, and then we looked at long-term follow-up. So not only are patients showing improvements after treatment, but they're also showing retention of those benefits, and that's extremely important. That concussion education and strategies management program I mentioned, this is a 6-week program. It can accommodate more patients than in the other modules because there's less interaction with patients. So, and it's a very structured module. Here's the sample of patients that went through this study, 80 patients, and this is a pretty typical snapshot of our patients, of our concussion patients, I should say. And our main exclusions for the entire program are being less than 6 months post-injury, having psychotic symptoms, and an inability to communicate in English. But otherwise, our inclusion criteria are very loose. And what we found was very good feasibility for this new concussion module. Really positive feedback from patients. And when we looked at their improvement in confidence to self-manage their symptoms, we showed nice improvement pre to post. And we also have been working at customizing treatments. So we're trying to customize treatments in order to increase impact. And, you know, we all know about customized medicine. So what we found was the patients that are improving most in this module are those who have the fewest cognitive and physical complaints at intake. Or I should say fewer. So if you had really high burden of cognitive and physical complaints at intake, you weren't going to show an increase in your self-management of symptoms after this module. When we look at mood, we see improvements in mood across the board. And here, what we found that was not surprisingly, the biggest improvers were those who had high symptoms at intake. So, and then the other thing I want to point out is that in all of our interventions, we find that age, education level, and time post-injury doesn't matter. So they're benefiting no matter how far they are post-injury, how old they are, what their educational attainment is. Okay, so I'm not going to bother summarizing these preliminary findings, and I just want to give you my global take-home messages. Dearth of resources for patients in chronic stages of injury, but also patients are missing treatment because of misdiagnosis, acute diagnosis. Treatments needed to prevent that vicious cycle of concussion, to optimize recovery of comorbid injuries, to prevent declines, and just to treat ongoing symptoms. Depending on our end goal, we can take a compensatory approach, or a restorative brain protection approach, or both. And then I talked about our tele-rehab center for ABI, where we try to integrate everything that I talked about. And I mentioned we're expanding to other provinces, so feel free to get in touch. And I think I'm just going to end there. So thank you very much. And if you have any questions, I think I'm able to field them. I don't know if anybody's asking a question. I can't hear anything at the moment, and I'm just trying to stop share. So I can't hear anything at the moment. Okay. Give me a sec. I'm supposed to unmute. I just asked to unmute. Can you hear anything? I'm going to speak, and maybe hang on. Hello.
Hello. Hello.
I can hear you now.
Hi. Okay. I was just asking if you are also looking at any physical activity interventions.
You. Sorry, there's feedback. Hear me? Can you?
I can hear you. Okay, I think so.
Okay. So we are putting involved intervention, running on contact, clinical television, no physical as yet, but it's something and all of the benefits as med. Future. I know there's online in the chat, so I'm going to respond to those. Again, I'm hoping you can hear me all right. Oh, it's better if I mute my mic. Okay, hang on.
What did I say? Technical issues. Dr. Green, are you able to hear me?
Okay, can you hear me now?
Yes, a little bit like a. Thank you very much for being here with us today. Oop.
Hang on one sec. Okay. Can you hear me?
Would you like to try again?
Sure. Hear you.
Okay, great. So I'm wondering whether it might be a good idea. Would it be much of an imposition, Dr. Green, if I were to invite the questions that we may still have in the audience, if they were to pose those questions directly to you after this in an email? Would that be okay? I'm just thinking of the technical problems that we're having.
Sure.
Okay. That's wonderful.
Take I can hear you.
Okay, wonderful. I will make sure that the audience has an email address and that the invitation is open for today. Thank you so much. You know, this makes me feel so normal. I think of all the Teams meetings that I've struggled with. Okay, thank you very much for joining us today, Dr. Green.
My pleasure.